everyone, welcome to researchmd.com. We got a great presentation today. We have to teach you everything about community-acquired pneumonia under 9 minutes, right? So we know how important the time is to you. All this we kind of compressed into a 9-minute format. The repetition is the key, my friends, okay? In order to retain in your brain, keep watching the video rather than spending an hour or 2 hours to watching one video. Short point-wise video, keep repeatedly watching it. That's why our presentation. Again, Dr. Pramil Cheriyath here, Program Director, Internal Medicine Residency, Transitional Residency. I'm a Director of Research. I teach medical student residents on a regular basis, and I'm also Assistant Professor of Medicine to large universities. And so when you look at the introduction, community-acquired definition, lower respiratory tract infection with one or more pathogen acquired outside the hospital setting. That's why we call it community-acquired, okay? Epidemiology is given right here. Everybody know that. Account to 3 million deaths globally. In the United States, 1.7 million ER visit. Risk factors, age, smoking, environmental exposure, gases, dust, fumes, chemicals, clinical condition, functional impairment, COPD, asthma, previous community acquired, and immunosuppression therapy. All of this, everybody know. Oral steroid, definitely high risk, and even proton pump inhibitor like omeprazole can put the patients at risk. Common pathogens, I think, is very, very important. You need to know what's the common pathogens, right? You got respiratory viruses, influenza A, B, streptococcus, mycoplasma, Haemophilus influenza, Chlamydophila, and Legionella, Staphylococcus, Moraxella, gram-negative rods. And when you talk about the causative pathogen, let's look at also the fungal infection causing pneumonia, coccidioidomycosis, Histoplasma capsulatum, blastomyces, pneumocystis, Aspergillus candida, and Cryptococcus neoformans. So let's look at some of the conditions and what organism you have to cover when they're present with. When alcohol comes with the pneumonia, always think about anaerobic oral flora because they can have aspiration, Klebsiella, Mycobacterium tuberculosis, Streptococcus pneumonia. This should be your differential diagnosis. And you have to rule out those causes also, like tuberculosis when an alcoholic patient come in. If it is aspiration, you need to cover for anaerobic flora, okay? For bioterrorism, expecting bacillus like anthrax, tularemia, plague, and all those kind of things. When a COPD person come with pneumonia, which is very common, or smoking, Chlamydophila pneumonia, Haemophilus influenza, Legionella, Moraxella, Pseudomonas, or gram-negative rot, and Streptococcus pneumonia you need to be worried about. When you have exposure to bat or bird dropping, there's like Histoplasma capsulatum, and HIV infection, there's like two differences between early HIV infection and late HIV infection. Early HIV infection, you got Haemophilus, Mycobacterium, Streptococcus, and late HIV, you can have Aspergillus, Cryptococcus, Histoplasma, Haemophilus, nocardia, non-tuberculous, and pneumocystic Gerovici. And then if you're in a hotel or cruise travel in the past 2 weeks, always have to consider Legionella pneumonia. And just to remember the facts, Legionella usually have abdominal symptoms. We have diarrhea. The hyponatremia is very common in this patient, okay? Injection IV drugs, what organism? Anaerobes, Mycobacteria, Staph aureus, and Streptococcus pneumonia is there. Lung abscess, anaerobic coverage important. Mycobacterium tuberculosis, non-tuberculous Mycobacterium, Staphylococcus aureus. And then when you travel, the residents in the southwestern USA, my friends, think about coccidioides hantavirus, okay? What is the pathogenesis a little bit? Pneumonia occurs, there's an alveolar infection when the immune system cannot clear the pathogens, right? Systemic inflammation, local inflammation factors, cytokine storm, and calling secondary symptoms like fever, chills, fatigue, pus in the parenchyma lead to decreased compliance is shifted, right? And then shunt in the perfusion, ventilation, breathing more difficult, risk of pneumonia highest among persons with reduced mucociliary clearance. That's like, the people who have cystic fibrosis, those who smoke also, the ciliary mechanisms kind of affected, condition leading to aspiration such as esophageal disorders, neuromuscular disorders, and cerebrovascular accidents. And signs and symptoms, if you look at it, fever, chill, very common, cough, increased sputum production, abnormal pulmonary examination, shortness of breath, chest pain, leukocytosis, the chest imaging with change in infiltrate. So dullness and percussion have the highest likelihood ratio, also decreased vocal resonance also, likelihood ratio wise, okay? So prediction, there's a prediction rule to diagnose. Use this to come if you are suspicion, and this will help you. Look at the likelihood ratio. Rhinorrhea, It's a negative likelihood ratio, okay? Sore throat, night sweats, and you put the points based on that. So if the patient has respiratory rate greater than 25, that's pretty much you can kind of point toward there may be something kind of else going on. Temperature 100 degree Fahrenheit or higher. So you put all these points and look at it. If you got 3 points likelihood ratio 14, that means your odds of getting diagnosed with the pneumonia is like 30, 40%, even 50% higher, okay? So if you have less than 1, there's pretty much a negative likelihood ratio, low chance of having pneumonia. Now we have to know how do you risk stratify. Why do we have to risk stratify? We need to decide, you need to put the patient in the hospital or you send him home. Use curve 65, okay? Look at the sensitivity and specificity, 100% and 82.3%. So use this. Confusion, urea, respiratory rate, blood pressure, age greater than 65. You got a nice table below that. Decide, 0 to 1 point, 2 point, 3 to 5 point, you might want to transfer the patient to the ICU. You need to know if you're taking a test, make sure you know this curve 65, very important, okay? Another nice scale, pneumonia severity index with all these risk factors. You get a score. If it is greater than 130 or 91 to 130, it's high risk. And then look at the risk score based on that. Very high sensitivity and specificity. You need to know how to calculate pneumonia severity index. Lab test, CBC, platelets, if it is 100,000 less than worst prognosis, CRP, serum procalcitonin, blood culture, serum sputum culture, even CMP also is important, right? Because you need to know like Legionella hyponatremia is very common. So very, very important to get all the basic lab plus the one we talked about it. So sputum analysis, when do you have to do sputum? You don't get in the habit of every pneumonia patient come in, don't do it. Only severe community acquired pneumonia. There's intubation, current empiric treatment or history of MRSA or Pseudomonas infection, hospitalization and parental antibiotic within the previous 3 months, and positive nasal screening for MRSA. Now, when you look at the chest x-ray, infiltrate on the chest x-ray, sensitivity is very low. Sometimes with 32%, specificity a little bit higher. So the finding lobar consolidation, cavity release, and pleural effusion, diffuse parenchymal involvement, indication for CT, complicated cases, pneumonia, febrile neutropenia, HIV infection, clinical suspicion of severe SARS, and very high sensitivity and specificity, my friends. Ultrasound also very good sensitivity and specificity, depends upon the operator, how many they did. So these are the classic finding you will find in the ultrasound: B lines, tiny areas of subpleural consolidation, hepatization, the Shred sign, all of this kind of very, very important. So this will be the future, I got a feeling. So when you have like patient come in, when you treat, it's very important to follow this nice, beautiful diagram. First thing always, pneumonia severity index, and then you do the classification based on that and put on the low risk and look at the comorbidities, then outpatient setting and the inpatient setting. You have to outpatient setting, you have monotherapy, depends upon the risk, and then you have nice diagram with the combination therapy and the drugs involved. In the hospitalized setting, we have another diagram right here. Inpatient, you look at the risk factors. Again, you calculate the curve 65. You decide based on the patient need to go to the ICU, a combination therapy, and if it is suspect Pseudomonas, you need to come with anti-pseudomonal therapy like imipenem. If it is the usual, it's the usual in the hospital, probably IV ceftriaxone plus macrolide azithromycin is the most common treatment you ever see, but depends upon the complications also. So what are the complications you're looking for? Parapneumonic effusion, empyema, lung abscess, staph bacteremia or strep bacteremia. All of this can cause like sepsis, infective endocarditis. You need to worry. Thank you so much for watching our presentation. We'll be back with another presentation soon. Please subscribe to our channel.